Okay, let's talk about anatomy, cardiovascular anatomy. So, cardiovascular anatomy, we have heart anatomy. What do we have here? So, left atrium is the most posterior part of the heart, high yield. Left atrium, most posterior part of the heart. Enlargement of the left atrium, example in mitral stenosis, can lead to compression of the esophagus, dysphagia, and or left recurrential nerve uh, branch of the vagus nerve causing hoarseness, which is known as Ortner syndrome. So, looking back here, what are we trying to say? We are saying left atrium right here, right? Is the most posterior. So this is all anterior. This is all posterior. So what is most posterior of the heart? Left atrium right here is the most posterior. So what is the most anterior part of the heart? Which is going to be written here. It is your left ventricle, right ventricle, my bad, right ventricle. So if you were to enlarge the left atrium, for example, in mitral stenosis, it can lead to compression of esophagus. Where is the esophagus? Right here, between your left atrium and aorta, you have esophagus, a black tube. Let me zoom in, try to tell you here. So this is going to be your esophagus. Or hypothetically, you can think, okay, it's esophagus behind that, okay? But the esophagus is there. Uh, Anatomically, either it's going to be here or here, okay? Uh, but it's going to be behind this left atrium for sure. So that esophagus. So if you increase the size of this left atrium, you're gonna constrict. You're going to compress the esophagus. That's one thing. On top of that, you could mess up your left recurrential nerve, which can give you hoarseness, which is known as Ortner syndrome. With that Ortner syndrome, the patient can develop they can have chronic cough. So hoarseness and chronic cough, right? Uh, Chronic cough, hoarseness, and dysphagia when you obstruct the esophagus, and that would be called as cardiogenic dysphagia. Cardiogenic dysphagia because of esophagus is blocked up, or hoarseness syndrome. Hoarseness, which is Ortner syndrome. Okay. Now the other thing is, let me change color. Right ventricle. So the right ventricle is the most anterior part of the heart and the most commonly injured at the trauma. For example, somebody gets a trauma, a knife penetrating injury from straight to the anterior part of the heart or thorax. What is going to happen? You're going to damage that right ventricle. When you damage that right ventricle, that's the most common part which gets injured in trauma, high yield. So left ventricle, this one. Let me change color. Left ventricle. Left ventricle is about two-third, and the right ventricle is about one-third of the inferior diaphragmatic cardiac surface, as mentioned in picture this one on the right side. So what do we have? Look at this right ventricle. This is about one-third, while look at the left ventricle is about two-third of the it is about two-thirds for the of the diaphragmatic cardiac structures. So this is all about heart anatomy. Now we're looking at the pericardium. What is pericardium? Changing color. Pericardium, it consists of three layers. Okay, what do we have? Three layers from outer to inner. Okay, from outer to inner, what do we have? So first of all, normally we have pericardium. What do we have after that? We have myocardium, and after myocardium we have endocardium, right? So we're talking about specifically epicardium at the moment. Epicardium has a fibrous epicardium and a parietal epicardium, and between the parietal is the between the parietal and the visceral pericardium, which is also known as epicardium, is going to be a space that is called pericardial space. Okay, pericardial space. So we have a pericardial space, a visceral layer of and the last one is the epicardium, which is the visceral layer. So what are we talking about? We talked about how. So we have the first is the fibrinous pericardium. Then you have the parietal pericardium. After that, you have the pericardial space, and then the epicardium, which is known as the visceral pericardium. Visceral means it is attached with the heart, right? So you can't really differentiate it. Above you have some space, and above that you have two layers on top of it. Okay, and it is denoted right here. You have the fibrous pericardium and the parietal pericardium, and then you have the pericardial space and the epicardium, which is also visceral, also known as visceral pericardium, which is attached to the heart. Now, where are the coronary vessels? The coronary vessels are going to be in the coronary vessels are where they, if you look here, they are within your epicardium. Okay, they are within the epicardium. Epicardium contains the vessel, important thing. Coronary vessels are in the epicardium. Okay, yeah. So we have we talked about how the vessels are. So again, let's just recall this thing and then move on to the next one. What do we have? Again, same thing, but the important thing is in the epicardium we have the blood vessels, and here's the space. Now, this pericardial space lies between the parietal and pericardium and epicardium. We talked about it. Pericardium is very high yield, is an innervative phrenic nerve. Pericarditis, which is inflammation of the pericardium, can cause rapid pain to the neck and arms, or one or both shoulders, often left. So this is the phrenic nerve. If you recall, the phrenic nerve, the roots are C3 to C5, and the phrenic nerve not only innervates the pericardium but also the peritoneum. So if you have peritoneal inflammation, peritonitis, you will also mess up this. It will irritate the phrenic nerve, will also give you a pain that is going to go to the shoulder, to the neck, similar, right? Now, very high yield is this coronary blood supply. What is the coronary blood supply? Where you have, let's actually draw it here. You have aorta, right? That aorta gives rise to, ascending aorta gives rise to LCA, which is left coronary artery, and RCA, right coronary artery. For LCA, give rise to LCX, three things: LCX, left circumflex artery, and also gives rise to LAD, which is left anterior descending artery, and the last one, which is OMA, the marginal artery. RCA gives rise to your PDA, and the last one it gives rise to is AMA, acute marginal artery. Now, the PDA is the dominance, right? And we will read that. Either it could arise from the RCA, or it could either arise from LCX, depending upon dominance. So let's read that dominance first. So dominance says, if you have a right dominant circulation, which is the most common, then the PDA arises with the right. So most commonly it arises from right here, the right side. That's the right dominant. But if you have a left dominant, it's going to rise from LCX, which is right there. All right. But if you have a co-dominant circulation, PDA actually arises from both, meaning the blood, both of them are joining together to form a PDA, both meaning LCX and RCA. Coronary blood flow to the left ventricle or interventricular septum, high yield. Coronary blood flow to left ventricle and interventricular septum peaks in early diastole. And what is that about? So if you recall, you have a heart, right? And this heart, it needs oxygen. It needs oxygen when it's contracting. It is such a forceful contraction that there is no blood that it can take. in the contraction time. So in the systole, there is going to be no blood that the heart is taking. It's only in the diastole, when the heart is relaxed and it is just filling the blood. At that time, the myocytes, the cardiomyocytes, are going to take up the oxygen. So same thing. So coronary blood supply, that's what they're trying to say here. Coronary blood supply to left ventricle peaks in early diastole because there is no contraction at that time. It's just dilation. Coronary sinus runs in the left atrial groove, high yield. Where the coronary sinus runs? Left atrial groove, and drains into the right atrium. Right atrium. Where does the coronary artery drain? Right atrium, high yield. Another thing which is not mentioned here is going to be, it is the most deoxygenated. It is the most deoxygenated blood of the body. Most deoxygenated blood is present in the coronary sinus. Now the versus, where is the most oxygenated blood? Most O2 is present where? It is going to be in the aorta, ascending aorta. It has the most oxygenated blood, and most deoxygenated is in the coronary sinus. Okay, now looking at each one of these things, let's change the color here quick. Okay, so we are talking about LAD. Let's erase this as well, I guess. Okay, LAD, left anterior descending artery, and its branches supply anterior 2/3 of the interventricular septum and anterior lateral papillary muscle and an anterior surface of the left ventricle, high yield. And I will make an image out of it. Let's actually do it while we read, because that's going to be easy. So let's just make an image. So we have right ventricle here and a left ventricle here. So LAD, let's give it a color blue, let's say. So LAD is giving rise to what? LAD and its branches, which is left anterior descending, in these branches, they supply the anterior 2/3 of the interventricular septum. They supply anterior 2/3 of the interventricular septum, which is right here. Two-thirds of the antero, meaning anterior, interventricular septum, meaning 2/3 of the anterior part of the interventricular septum, right? And it also supplies to the anterior wall of the left ventricle. So 2/3 of the interventricular septum, and also supplies to the anterior lateral. So I'm just going to write AL. AL of the papillary muscle and anterior surface of the left ventricle, right? So this is about LAD. Now changing color, what about PDA? PDA supplies posterior 1/3 of the interventricular septum, posterior 2/3 of the walls of the ventricle, and the posterior medial PM of the papillary muscle. So this posterior part of the interventricular septum and posterior wall of the 2/3 of the posterior wall of the left ventricle. So this is all PDA. Now changing color, let's look at this. What is RCA doing? RCA supplies the AV node, the SA node. Infarct may cause nodal dysfunction, bradycardia, heart block. Right acute marginal artery supplies the right ventricle. So they are saying all of this right ventricle, it is supplied by RCA branch, either RCA or the branch of RCA, which is going to be your right marginal artery, or right marginal artery, or acute marginal artery, AMA is mentioned over there, right? So here's these. Now you recall, hey, something is left here, right? What about LCX? They haven't mentioned here LCX. Okay, let's just talk about LCX. I don't know why they haven't mentioned LCX here, but let's look at LCX. LCX would supply the lateral wall of the lateral wall of the left ventricle and the posterior 1/3 of the lateral ventricle, and also it's going to supply to the anterior lateral papillary muscle, which is right here. Okay, so So this is sort of a blood supply of heart. So coronary blood supply. So let's just recall the whole thing. What is the coronary blood supply? Well, the coronary blood supply is as follows. You have this lad. Lad would supply. Wait, color changed. Lad supplies the in Lad would supply the in 2/3 of the interventricular septum anteriorly, and also the anterior wall of the anterior wall of the left ventricle. This is left ventricle, remember? So anterior wall of left ventricle and 1/3 of 2/3 of the anterior ventricular septum. PDA supplies the posterior 1/3 of the interventricular septum, and then also posterior part of the posterior 2/3 of the ventricular left ventricular wall. LCX supplies the lateral wall of the left ventricle and also 1/3 of the posterior wall of left ventricle. RCA is easy, supplies all of the right ventricle, and on top of that it also supplies the SA node and AV node. And if you were to mess up your RCA, now let's talk about some messing up, right? Like if you have ischemia. If you have ischemia to RCA, you will give it's going to cause ischemia to the right ventricle. On top of that, the SA node and AV node won't work, so you're going to go into bradycardia and heart block, right? And important one. LCX supplies the anterior lateral part of the papillary muscle, and also it is also supplied by LAD. So LAD and LCX, they both supply the anterior lateral. Why is that important? That is important because the posterior medial is only supplied by PDA. The posterior medial wall of the papillary muscle is only supplied by PDA. So when you knock out your PDA, meaning when there is an ischemia, there is an MI causing infarction to the PDA, you are going to infarct the posterior medial papillary muscle, and it's going to give you mitral regurgitation. Because there's only one supply to the posterior medial papillary muscle, while there's a dual supply to anterior lateral. Why that is important? Because even if you knock out your LAD, you will still not knock out your anterior lateral papillary muscle, causing this. You will not knock out your anterior lateral papillary muscle, so there will be no MR, mitral regurg. Okay, so that's pretty much all for coronary blood supply.